Obesity is one of the most prevalent chronic diseases in the world, affecting billions of individuals and causing over 1.6 million premature deaths through comorbid conditions like diabetes and heart disease in 2025 alone. What's more, 2025's World Obesity Atlas predicted an increase of 115% in the total number of patients with obesity between 2010 and 2030. Significant strides have been made in the management of this disease over the last few years, between the advent of GLP-1 medications and the recent definition of clinical versus non-clinical obesity. However, significant roadblocks still exist. Foremost among these is the immense stigma surrounding the condition. For decades, society has viewed obesity as the result of poor lifestyle choices, blaming the patient for their condition. This has led to a substantial taboo in discussing the disease in a clinical setting, and the responsibility for bridging this gap often falls on clinicians.
I think the first thing we gotta do is address weight bias, and so, it's a hard subject to, like you said, to somewhat, uh, talk about, and in my realm, I run I am a primary care physician first and foremost, and then I have my weight loss practice, but, I'm kinda used to, asking for permission before we talk about anything, and I think that's a really easy way, just like, for example, when someone comes in and it's a visit where you're just doing a routine follow-up on their chronic conditions, but then you notice that their mood has been down, right? And you ask for permission, like, "Hey, I saw your depression screen today. Can we talk about this? Is it okay?" And you kind of do the same with weight. If we can approach it from a sense of compassion, I think patients are a lot more open to talking about it. And so sometimes it's as simple as, we've been talking about your high blood pressure for a while now. Uh, but I noticed that we've been tracking your weight and it's been going up. Is it okay if we talk about it? And sometimes I think the word obesity even has some negative connotation to it. That's why with my patients, I just call it weight and then talk about how weight could be the root cause of some of these chronic conditions. And just like we treat blood pressure as a vital sign, if we can learn to treat weight the same way and talk to our patients that there's choices out there and tools out there that we can use. And then really talking to them about their lifestyle changes. And then that's the goal. And that's the hope for a healthier country, right?
I think that's the one of the biggest, but I think the big obstacle for patients seeking treatment for obesity because they were educated that it's their fault. They are guilty for wrong choices. They're guilty for being not being active, physically active. However, if we look at uh, the new definition of obesity that came from the Lancet Commission, if we define obesity as excess adiposity, period, and then we can stratify them into two categories in a spectrum. The preclinical obesity would be those with excess adiposity without any of the signs and symptoms of obesity. To make a long story short, it would be people without any organ dysfunction secondary to obesity or an impairment of their daily life activities. And the spectrum progresses with people with excess adiposity plus signs and symptoms and or conditions that impair their daily life activities. So if we show them that it's a disease that has a spectrum of progression, and then we can change the strategies and the intensities of treatment depending on the staging of their obesity, their excess adiposity, we can uh, move the needle towards showing them that it's a disease biologically active, and then we need the foundation of lifestyle changes that the 8 billion of people who live in the world should do this on top with depending on the risk in preclinical obesity treat them with medications of surgery, and then in the persons with clinical obesity an active biological disease to be treated right now, prioritized. So I think showing them that this is the way to go, it will mitigate the effects of all the burden that they had over their shoulders, being guilt, with the guilt and being guilty of a disease that it's not a choice.
In addition to the stigma surrounding obesity, the myriad treatment options that have entered the sphere in recent years are in themselves a double-edged sword. Semaglutide and tirzepatide have opened entirely new pathways for weight loss, thanks to their extreme efficacy, but they can often lead to weight regain if the medications are stopped without layering lifestyle interventions on top. Additionally, the complex treatment cascade for obesity can be paralyzing in its own right, leaving many clinics forming their own strategies and approaches when prescribing treatments for obesity.
From us, like, especially through the Obesity Medical Association, the OMA, one of the things that we talk about is the 4 pillars of OMA, which is diet and exercise, behavioral therapy, medical, uh, medical intervention, and then finally bariatric surgery, right? And what the one thing that we do want patients to understand is that even when we start medications, it's not a replacement for lifestyle. It's meant to be adjunct therapy, right? And so patients tend to have better outcomes if they tailor their own lifestyle in addition to taking the medications. So, for example, when somebody has, like the one classic example I give my patients, when somebody has high blood pressure, we're putting them on blood pressure meds, but we're also telling them, "Hey, get some regular cardiovascular exercise, try to reduce your salt intake," right? Kinda similarly, we wanna do the lifestyle changes too. So we're talking about, proper nutrition, increasing protein and fiber in your diet, getting regular exercise, whether it be cardiovascular, incorporate strength training because as we lose weight, we lose muscle mass, and we wanna retain muscle mass. And then we understand that even though a patient does all of this, they don't always get to their weight loss goals. They'll have a what we call a set point where they'll have a stall in the loss of their weight. And at that point, we use medications as a tool in addition to their lifestyle management to get them to their goal weight. So it's more of like an adjunct added benefit than something that somebody should do solo. And even if you did medication solo, you won't have the most yield, right? You won't have all the benefits because any medication does have side effects, and a lot of these medications cause constipation. So when you're tailoring your lifestyle, you're eating healthy, you're moving more, you can also mitigate these side effects. And so, main thing that patients don't understand is not meant to be medication's not meant to be solo therapy. It's always an adjunct to lifestyle. So that's usually how we go. And then patients have to meet certain criteria before we can even talk about, medication management. So, for example, a BMI above 30, which is considered class 1 obesity, or a BMI above 27, where you're overweight, but you have to have 2 comorbid conditions, as we call them, like conditions that are related to weight. So, like prediabetes, high cholesterol, high blood pressure, etc. So they still have to meet criteria, but that's usually how we start.
However, for every limitation and shortcoming in this sphere, several more steps forward have been taken. Recent publications have highlighted obesity's role as a risk factor for diseases across the clinical spectrum, including cancer, heart failure, stroke, chronic kidney disease, and more. This has led to a surge of interdisciplinary work among various specialties in addressing obesity, as well as emphasizing its dangers to the patient population.
I think there definitely has been a shift, of more interdisciplinary work because and it's not even just in, the clinical sense. We see that patients are a lot more aware now, and it's even seen on, uh, for, like, things social media, right? I like uh, this concept of prioritizing protein as we see it with new dietary guidelines, and now you can even get protein in coffee, you know what I mean? Starbucks is selling it, but, I think what's been happening is that we're more aware and we're bringing more light of how much weight contributes to comorbid factors, and not just in primary care, but we see cardiologists often starting GLP-1s on patients now because we understand that it's the root cause, and, I apologize. Sorry, my friend, I got like a spam phone call there. No problem. Sorry about that. But like what I was trying to get at is even cardiologists are talking about that now. and they're starting GLPs because we know that the cardiometabolic risk that come from weight are significant, and it's been even included and mentioned in the new blood pressure guidelines. And the more we're researching how much weight contributes, the more we're seeing in different specialties of how weight reduction can help. So, for example, in GI, the GI docs deal with not just colon and esophagus, but also the liver. And we know that fatty liver disease, or what we call metabolic associated steatotic liver disease, weight is a contributing factor. And Wegovy or semaglutide has had independent approval for MASH or MASLD, and it's typically started as a weight loss medication, right? And it doesn't even end there. We're looking at that in rheumatology now, with possibly weight reduction helping autoimmune diseases, and even in psychiatry, thinking maybe, who knows? There's some studies out there that's looking at weight reduction and decreased incidences and even depression. And so I think we're being a lot more aware. Some of it could be that there is a little bit of like a kind of financial aspect, even some geopolitical aspect happening with the wake of these new GLP-1 medications and the freaking impact they're having on the country and on globally as a scale. But with that, the side effect is people are a lot more aware now, and I think it's becoming uh, more kind of in the front page now, and we're trying to work as a team rather than, hey, this is weight, uh, talk to primary care, eat less, and exercise more. Right? We know it's more multifactorial, and I think that's the great step in the right direction.
Ultimately, as with every condition, more work needs to be done to address the ongoing obesity epidemic. From circumventing the social stigma to addressing limited awareness and furthering education, clinicians have no shortage of paths forward. Here are some words of advice from leading clinicians in the obesity space, highlighting where work must still be done and how the medical industry as a whole can begin to fill these gaps.
First, avoid diagnostic and therapeutic inertia. So people still is unconscious, maybe in the general practitioner, the GPs, that obesity is a bad behavior. Obesity, it's not a, it's as we start speaking on our conversation, that it's their fault. So first, they have to eliminate their intrinsic bias. There's a very interesting study that I'm sure you're aware that persons involved in the treatment of obesity, they spend less time than people without obesity. So a consultation in a person with obesity takes around 15 minutes on average versus 25 minutes in person without obesity. So this is an unconscious bias. So I think the first thing to do is to destroy that barrier to treatment. And second, understand the need of the patient, understand what specifically we're going to prescribe to him or her, drugs, surgery, combinations, endoscopy, whatever fits for the patient. So I think the advice I would give, the first one, please think before you see the patient, because your attitude may undermine all the efforts that we're doing to bring more people on board to be treated, and they need, deserve, and should be treated of their condition, of their disease.
We really don't have enough. When I was in medical school, right, and even in endocrine fellowship, I didn't really learn much about obesity, so we just have a whole healthcare force out there that really hasn't been trained well in obesity, so we have to kinda pick up the pieces now that we have these transformational tools, and the patients know about them, and the patients want care, so they come to the doctors, so really, we really need doctors to kinda become acquainted with kind of a guideline-driven care, what's important, how to kinda gather, data and an evaluation that can predispose to complication-centric care, get patients on these medicines, know, how to manage these medicines, know what the potential side effects are, how to deal with those, and then what we're really lacking right now is long-term medication persistence. So many of these patients stop taking the medicine after 1 year or so. It's multifactorial. But I think as healthcare professionals, we have to really talk to our patients about this and educate them and let them know, They need to stay on these medications. If not, weight regain is likely, and the health benefits of that weight loss will also disappear. So, physicians just have to acquaint themselves with this through continuing medical education, or, um, uh, you know, there's just I don't have a magic answer for that. But when patients start coming to doctors and saying, "I want you to help me with this," then we tend to learn pretty quickly.